Good evening, and welcome to the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, which is the Laborers International Union of North America. I'm Leslie Rattan, and I'm really pleased to be moderating our webinar series, which has been developed for people struggling with persistent concussion symptoms, for caregivers and family and friends as well. So as many of you know, the sessions are recurring every other week, live on Tuesday evenings. And also, just so you know, the sessions are all recorded and are available a bit of time after the live viewing, so that you're able to go back and watch them after the fact. Each of the sessions are focusing on various aspects, various symptoms of concussion. And the format, if you haven't been here, we have an expert speaker who will talk to us on the topic for the first half hour, and then that's followed by a half an hour of questions and answers. So if you have any questions, please feel free to enter those into the Q&A. If you just scroll to look to the bottom of your screen, you'll see a Q&A. So you can enter any questions that you might have there, and we'll do our best to get to those after the presentation. If you have any technical difficulties, please enter those into the chat, and Christian will help you out there. We're going to just run a quick poll. Christian's going to put that up. It's helpful for us to know who's in the audience. So if we can just pull that up, and if you can just indicate who you are, that would be most helpful. Thank you. So I'm really pleased this evening. We've got Dr. Mark Bayley with us, and is going to be talking about exercise therapy and concussion. Dr. Bayley is Program Medical Director and Physiatrist in Chief at UHN Toronto Rehab Institute. And he's a professor at the University of Toronto in the Division of Physical Medicine and Rehabilitation, Faculty of Medicine. And Mark has held a number of health system leadership roles, including chair of the Stroke Evaluation Committee at Core Health Ontario, Brain Injury Committee at the Ontario Neurotrauma Foundation, the Canadian Stroke Best Practices Committee, and the Vice Chair of the GTA Rehab Network. He is also a clinician scientist with an interest in recovery from brain injury, concussion, and stroke. He's involved in many studies of interventions to speed recovery, and has also been very interested in implementing the best practices at a health system level in the areas of stroke and brain injury rehab. Initially through the stroke guidelines for the Canadian Stroke Strategy, a smartphone app to determine post-stroke arm rehab, and guidelines for concussion and traumatic brain injury. And with that, I will turn it over to Mark.
Thank you so much, Leslie, and thank you for the introduction. I'm really excited to be here and just talk a little bit about something that I think we all feel is an important element of recovery from concussion. So I'm going to see if I can keep everything working. It's not work. Okay, so over the next few minutes, what I would hope to do that is really, so by the end of this, you should be able to describe why we should consider exercise therapy after concussion, how we might determine what is the right dose and intensity of exercise, and how to gradually return to activity regardless of where you're starting. So a lot of people say, well, a lot of people have heard that, rest and rest and rest and until you get better. And so I really wanted to talk a little bit about why we might believe that exercise actually might be helpful. So this is just a reminder. I hope you'll see the video that when a concussion occurs, the brain gets shaken within the skull, and it, if I can get the video working, it's cooperating. I cannot, sorry, it's not moving, but the brain moves within the skull, and this results in a number of problems. The first problem is that all of those millions of connections in the brain, which are called axons, which connect the various nerve cells to other nerve cells, can be stretched or strained. And there's particular areas which are vulnerable to that. Second of all, in a more severe brain injury, you can see the nerves actually break. And sometimes there may be weakness of the walls of the artery, which may cause some leaking or injury to the nerves. And so this is also associated with changes in the functioning of the nerves. And this is what happens is that this is a picture of nerve cells. And when they are shaken and injured, you can have slowed processing, but also you may see decreases in neurotransmitters that are important for memory or mood. And this can explain why we see this. And so these are some problems at the neuronal level that we need to deal with. Another thing that's been recently observed by our research group at UHN has been post-concussion changes in the way that your blood vessels and your brain react to changes or react to stresses such as breathing in carbon dioxide. And we actually have shown that people with concussion early on have a very different response to the stressors like carbon dioxide, so that we see changes in the way the blood flow is regulated. So obviously you can see that whether the nerve be stretched, whether the chemicals, the neurotransmitters change, or the blood flow changes, this can all result in a number of problems that we see in concussion. And this is one of my favorite explanations of concussion, which is really that there's a vicious cycle that the concussion will initiate. If you have a concussion, you can have both physical symptoms and cognitive symptoms. And the physical, it doesn't matter where you start on this cycle, the physical symptoms can result in difficulty with you paying attention, and you have a headache, you're dizzy, you can't really, focus on what the guy at the front of the room is talking about. So therefore, that makes you have trouble with remembering things. Then if you start to get overwhelmed because all these noises and I got a throbbing headache, it can create anxiety, which then creates muscle tension, which then goes and aggravates your physical symptoms. And so it goes round and round this cycle. If you look at the kind of problems that we have with a concussion, they can be roughly divided into physical, cognitive, emotional, and sleep. Physical symptoms we can see are headache, nausea, sometimes vomiting, balance problems, dizziness, visual problems. And these are very much things that might be of interest to us in terms of exercise. We also know that once you start to get these symptoms, this sensitivity to light, this numbness and tingling, that what might happen is that you start to avoid your symptoms. And this is a diagram borrowed from my colleague Noah Silverberg, who talks about, your concussion causes your symptoms. And then you're worried, am I going crazy? Like I'm really feeling rotten. And then you start backing up from doing anything. And then you get into this thing where I'm afraid of doing anything because my headache will just get worse. And then you become very sensitized to your everything. You're very hypervigilant. You don't really want to try anything. What does that do? You're inactive. And then because you're inactive, your muscles get weaker. You get more intolerance to exercise. And so you get into this cycle of inactivity, avoidance, and it gets worse and worse and worse. So, basically, this is why we believe that it's important to address all of the symptoms, including some of the cognitive and emotional symptoms that I was talking about with this avoidance. So then you might ask, how could exercise help? So let's go back over the problems that I told you about. The first one is the stretching or breaking and leaking that the nerves might have. And we know that exercise in research appears to increase nerve growth factors like brain-derived neurotrophic factors in normals as well as in people with concussion, resulting in brains being more resistant to loss of brain cells as people age, and it also may increase recovery. This has been shown in animal models as well as some humans. So what if the problem is your blood flow and it's not regulated properly and you're not getting enough blood flow to the right areas? Well, we know that exercise stimulates the blood vessels to send the message or send the blood to the area that needs the blood. And so it could correct the changes in the autonomic system and the dysregulation we see in concussion. And finally, if you've got a headache or whatever, it is well known that exercise can reduce the perception of pain and reduce migraine intensity in those with severe headaches. So exercise results in release of neurotransmitters and things like endorphins or endocannabinoids that can be relieving for pain. So what about this avoidance? Now you've got into this cycle. I can't do anything because as soon as I start, I get a headache or I get dizzy. Well, when gentle and graded exercise with supervision could reassure people that the exercise is safe without markedly increasing your symptoms. So just being able to show yourself that I did a little bit of exercise and actually did something can overcome that avoidance that you feel. And we also know that exercise increases levels of serotonin and adrenaline, and it is in people with depression almost as effective as medications for improving mood and anxiety. So it's almost as good as medications for people with symptoms of depression. And we also know that people who do aerobic exercise appear to have an increase in their depth and their quality of sleep, which we know is a concussion complication. So you can see that in contrast to what people have believed up till now, exercise could have a large number of benefits. So then we know that it is not without risks. So there have been concerns that what if we do the exercise, it could cause the injured nerves, they could become more inflamed and swollen. If we exercise too early after the concussion, the brain cells could be stressed with the alterations in blood flow, and overdoing the exercise may cause some more damage. And we also know that exercise could increase the amount of excitatory neurotransmitters, which means basically the stimulation from other neurotransmitters and chemicals in the brain that may be too high and could be toxic. So all of this has been brought forward as a concern, and we know that this window of concern in animal research and increasingly in humans, we find that this is probably true in the first 24 to 48 hours after injury, that we can overdo it, that we need to be careful, that people need to rest. So in that first period of time, it does appear that this is an important window that we have to pay attention to. So then when you look at how long should people rest then? Well, emerging world experts like the Berlin Sport Concussion team and other people have studied this. And there's currently insufficient evidence that prescribing complete rest achieves these objectives. So in other words, most people who try to rest have trouble doing that. But after a brief period of rest of 24 to 48 hours after the injuries, people should be encouraged to become gradually and progressively more active while staying below their cognitive and physical symptom exacerbation thresholds. So in other words, their activity level should not make them worse. So in athletes, it's important to know that we avoid vigorous exertion while they're recovering. So that time for that avoidance of a vigorous exertion is still under study, but maybe as long as 1 to 2 weeks in terms of returning to normal things. So in summary, why should we consider exercising? Well, after 24 to 48 hours, it could enhance your brain growth factors, restore normal blood flow, reduce pain, reduce anxiety, and reassure people that activity is safe, increase mood elevating neurotransmitters like serotonin, and improve sleep. So then you might say, okay, so it sounds like it might be worth trying. So then the question is, what's the right dose and intensity of exercise? And so this is a subject of much study. And this is a good systematic review that was done by Dr. Noah Silverberg and Grant Iverson, where they looked across different studies of of exercise and reactivation. And what they found was similar to what the Berlin group said, was a graded resumption of regular pre-injury activities, with the exception of competitive sports, as tolerated within the first few days to weeks post-injury, regardless of how symptomatic you are, is more likely to speed up than delay recovery. And the delaying graded resumption of those activities beyond a month probably worsens outcome. And since that publication, there's been continued systematic reviews. What do we mean by a systematic review? That's where researchers look across all the published articles. And you can see that these are just 4 of the articles looking at exercise for an active rehabilitation and you can see that there are many studies in this area. And this is just a quick overview of some of them. And just to kind of highlight when most of the exercise is occurring. You know, a lot of these studies look at exercise more than 4 weeks from the injury. Some of them 2 weeks, some of them less than or equal to 10 days, like the John Letty from the University of Buffalo study. And then we have others from Canada that looked at less than 10 days. But in all these different groups, it does appear that there was a reasonable outcome. So then this is really, so how do I know what should I do? So this is my general rule of thumb, which is similar to the Ontario Lottery and Gaming slogan, which is know your limit and stay within it. So what we need to know is, how do I know when I'm overdoing it? How do I know that I'm really not causing worsening? And so this is the question that a lot of people raised. And so what we've been doing in research and other places is to sort of put people through what's known as an exercise test. And the one that we've been using is called the Buffalo Concussion Treadmill Test. And in this test, the person walks at a brisk pace on a treadmill, and the exact speed is dependent on their height, and the speed is constant for the first 15 minutes. And every minute, the treadmill incline is increased by 1 degree. And once the treadmill reaches the max incline, the speed is increased. And we look at their heart rate, their perceived exertion, and most importantly, we look at their symptom severity on a visual analog scale. And so just to show you how this worked, we actually made a video. So if you'll forgive me, I'm just gonna stop sharing this screen and show the video to you. Okay, so here we are. I'm going to share my screen again, and we are going to. Okay, so I will rely on Dr. Rattan to tell me that you can hear it, but I'm gonna just. So this is a typical test within 1 week of injury.
So we're going to do the Buffalo Concussion Treadmill Test now. So what we're going to do is we're going to get you on the treadmill walking at a brisk pace. So you won't be running, you'll just be walking fast. Every minute, we're going to increase the incline as long as you're not symptomatic. So at the end of every minute, I'm going to ask you about any symptoms you're experiencing. And if your symptoms do start to increase just by a little bit, we'll stop there and we'll do a quick cool down. Okay? I'm also going to ask you about your exertion every minute, and we'll show you the scales before we start. To monitor exertion, we use the Borg RPE on a 6 to 20 scale, with 6 being no exertion at all, up to 20 being maximal exertion, the hardest they've ever worked. To monitor participants' symptoms, we use a visual analog scale, where 0 is they feel terrific, they have no symptoms at all, and 10 being the worst, that they feel terrible, the worst they've ever felt. Ready to get started?
Yeah.
Okay. We're going to start the treadmill. Based on your height, we'll be walking at 3.2 miles an hour, which is about 5.1 kilometers an hour. Like I said, it'll be a brisk pace. This is the pace here. So as we come up to the first minute, I'm going to see if you can give me your heart rate again.
89.
9. And how's your exertion?
Probably an 8.
8. And your headache?
The same.
Same one. Dizziness
About the same. Hold on.
and nausea.
That's the same.
Okay, okay to go up?
Yeah.
Okay, coming up to 4 minutes now. Did I get your heart rate again?
It's 104.
4. Your exertion?
14.
14. Your headache?
That's a 2.
2. Dizziness?
Probably a 2 now.
Okay, and nausea.
That's the same. Two.
So we're actually going to stop there. So I'm just going to bring you down to 0 incline first. And just bring you down to 2 miles an hour or about 3 kilometers an hour just to cool down. We don't want your symptoms to increase any more than that. Go with exercise. And so we're going to do 3-minute cool down. And we'll do the same kind of readings at 1 minute and then at the very end.
Okay.
That's a quick overview, and we just to kind of recap what we were doing there. We were looking at the symptom score, and the person went up by 3 points, and that's when you stop it, because you really don't want to push them too far through their symptoms. And so this kind of gives you a sense of how the test works. I'm just going to go on to the next slide. So just to remind you, it's usually stopped when their visual analog score, symptom score increases by 3 points, or they reach 80% of their max, or 20 minutes have elapsed. So that's a person who's considered to have passed the test, or they are able to get greater than 18 without any symptoms of concussion, or if they're really, really tired and they have any other symptoms that we need to stop it for. So then, this gives us an idea. So what do we have at the end of this? We have an idea of what the maximum heart rate that we want to go after and the effort level that we can then use. And so then we would start with telling the person, okay, this is where you should be exercising. This is the heart rate you're aiming for to stay under that threshold. And so then how do we progress people through return to activity? Well, this is kind of a well-known progression that many teams are using. And basically, as you go through the steps, at first, you obviously have no activity, which is usually the first 24, 48 hours. Then we start with light aerobic exercise. Some people like to walk or swim. I find that stationary cycling is often good because it's not the trauma of walking or swimming where you're twisting your head, but walking is very easy and everybody can do it. And you want to go at about 70% of your maximum predicted. So you don't want to go really near where your threshold is. Then if you progress to sport-specific exercise, which is skating drills in the case of ice hockey, running drills in the case of soccer, but there's no competition and no head impact. And then you do non-contract training drills where you're bringing the skills back in to get your coordination back. And then you should progress to full contact and then return to play. So in most cases, there is very little, there should be no way that somebody could who had a concussion, particular sports athlete, should return to play in a shorter time than 6 or 7 days if they really are progressing through these, because you have to give people a day at each stage. So then I just wanted to kind of spend the next few minutes of the talk just kind of highlighting a little bit of the work we've been doing on can we do this in adults, because this has been done in athletes, young athletes, by John Letty and the Buffalo team. But we thought, could we do this in adults? So this is just a quick overview. We at UHN at the Hull Ellis Concussion Clinic, we enrolled people who were coming into our clinic in week 1, and they would undergo the test to see where they were at, and the physician would see them. And then those people who were randomly assigned to one of 2 potential treatments. The usual care, they were told how to exercise, but they were not prescribed a specific dose. And another one were given a specific prescribed aerobic exercise. And each person was given a heart rate monitor, and they were given heart rate testing at at week 1, 2, 4, 6, and 8. So this is just a quick overview for our pilot. We were mostly looking at younger adults, 18 to 45. They had to have enough symptoms, like more than 9 on the sport concussion assessment tool symptom score. And then we needed people to have a low risk for cardiac disease and willing to exercise. If they had other reasons that they couldn't participate, like they had orthopedic injuries, or they had dizziness that was very severe, or they really were not, they were excluded. So then we looked at this group, and they were very similar to the group that we enroll in the 400. So this is 20 people that were enrolled in this study, and they had similar measures of symptoms as other people that we see on our routine group. And most people completed about 10 minutes on the test. They usually got to about 130 beats per minute. Actually, some of the people had actually recovered according to the Buffalo Concussion Test and were exercise tolerant. And some people were able to get up to 18. So we were able to do the test, and it was feasible in this group, getting people right off the street. They were referred to us by the emergency rooms. And then the doctor would give them an exercise prescription. You can see we would tell them what they would do, stop or avoid, and they should start what they should start doing in that framework I gave you. And then we gave them the type of activity we recommended in the minutes per week, and then the intensity on their target. And so just to kind of give you a quick overview of what the group did, most people were in the study for about 19 days. We had some trouble with people wearing the monitor at times so we could see their daily routine and activities. So we only got data for the heart rate monitor on about 30% of people. We looked at how many people were actually participating in the exercise, and we see that that people did not completely fulfill all of their prescribed exercise. However, we noticed that it really was hard for this group who are not athletes to continue to follow the prescription we gave them. Nevertheless, we would, if they were doing well and they participated in the study, they would be considered to have recovered if their SCAT score, their symptom score went at less than 9, if the clinic physician said that they were already doing back to their normal activities, or they reached 80% on the Buffalo test. So, and you can see that in this study, the group that participated in the treatment seemed to have reached their recovery at a faster rate than those in the control group, which is in red. And so, and they were actually better than our population of people from the clinic who are in black, who didn't get this exercise. So it appears that even in adults, not just in athletes, exercise appears to improve the number of people recovered at 8 weeks. So we know that if you're working in a clinic, that not everybody's going to have a Buffalo concussion test, and it might not be easy to administer. But what if you don't? Well, first of all, you can start activity that's tolerable given your other causes of pain, like neck pain, knee pain, hips and ankles, and pick an activity that probably will not exacerbate your other symptoms, like your neck or whatever, like walking, stationary biking, or swimming. And you should be looking at working at no more than 70% of what's perceived as your maximum for effort. And you should plan to exercise for just less than the maximum time. So if you know in the first few days you've been walking and after 16 minutes you get symptoms, you should not be walking more than 13 or 14 minutes and stopping for the day. And then if you did really well and you feel good later in the day, go for another walk for 13 or 14 minutes. But again, staying below that threshold. So really the take-home messages about this is that why exercise after 24 to 48 hours post-concussion really is possible. It can improve better brain function, blood flow, neurotransmitters, mood, pain, and sleep. The dose, know your limit and stay within it. And you may consider using the Buffalo Concussion Treadmill Test. And it seems to be that we can improve recovery through early subsymptom aerobic exercise in both athletes and the general population. So with that, I'm going to open it up and just say that some of you may be interested in, is there any literature on whether you should do resistance exercise? And there isn't as much literature on whether, weightlifting and things like this are better, but we do believe that the principles are probably the same, that moderate activity that does not increase, your pressure on your brain or the straining in your brain because of lifting heavy weights is probably helpful. And there are also exercises that can be used for dizziness as well. So in conclusion, I just want to stop and thank our team and the support of the Canadian Concussion Centre, who've been involved in a lot of this work, as well as would be remiss if we didn't thank the team from the University of Buffalo, Dr. Letty, Hayter, and Willer, who really have been helpful in teaching us how to do the Buffalo concussion test and working with us collaboratively. With that, you can also follow us if you're interested in concussion research on Twitter. We post new articles and things about concussion most days. And so with that, maybe I'm going to finish, Leslie, and open it up for questions.
Great. Thanks so much, Dr. Bayley. That was really interesting. Excellent presentation. Just to remind you, if you've got questions, please put those in the Q&A. And just a reminder to people as well that if you want a PDF of Dr. Bayley's slides, you can actually find those. Christian very kindly put those in the chat. So if you go to the chat, you can find them there. So we will go over to, we have a question from John. Is there a subgroup of patients who benefit from even low intensity exercise?
So that's a great question as to, whether or not even lower, I'm assuming it means lower intensity than, just the very, very mild. Yeah, I think the most important thing is just to get people moving. And for people who are highly symptomatic, that may be a very minimal, like people who get, a headache when they start walking, it may be as low as a few minutes is all they can really do in the early days. So yes, but yet we still believe that group may benefit from low intensity exercise. They may not benefit from all of the things we talked about, like they may not have exercised for long enough to stimulate brain-derived neurotrophic factor and things like this, but they will have at least got their brain active and some of the benefits will be present.
Great, thank you. Someone's asking, from your BCTT study with non-athletic adults, what was the reasoning for excluding a participant if they were taking a tricyclic antidepressant?
Well, that's a great question. We were, so there's a few reasons. I think we were just trying to be careful. Tricyclic antidepressants can have different effects on the conduction in the heart and the response of the heart. We also are aware that they can be sedating, and they may confound the results so that people might not be. We might not be able to see the recovery because they're recovering as a result of the tricyclic antidepressants. We know that they can be used for headache management. So we just wanted to keep a clean cohort of people so that we weren't mixing up medication effects with the effects of the exercise.
Mark asks, thank you, Dr. Bayley, for sharing today. Is there an exercise guide? So for example, specific exercises, frequency, intensity, etc., that I can reference as I am a multiple concussion survivor still experiencing symptoms after, it sounds like, several treatment programs? So
yeah, I think this is where it is challenging, and you're going to need, if you've had multiple concussions, you'll need to figure out what exercises make my symptoms tolerable. So I have had individuals who have concomitant neck pain, and really bouncing around, walking is just intolerable to them, or they have neck pain, and when they're swimming, they can't turn their neck because it does problems, or if they have high amount of dizziness, swimming can be very difficult because it provokes their dizziness. So I think that we really try and make an effort to say, first of all, make it functional for you. Like it could be just doing your normal routine of walking stairs, doing the things you'd like to do. So really returning to normal activities, combined with probably walking or an exercise like stationary bike at those areas that are tolerable for you. So I really think that I'm really a big fan of bikes because I think they're the least provocative for symptoms, and you can really calibrate your effort quite well. I don't really have a example, but what I would suggest you do, there is a patient version. If you go to braininjuryguidelines.org, there is a lot of resources. There's a patient version of the concussion guidelines. So it's braininjuryguidelines.org/concussion. And in it, it gives some examples of things that can be done. So I think that's one place you can go. I know that there's also a number of apps like the Parachute group at Parachute have a concussion tracking app that helps people track things. So that's another place you can go. And if you just look up on YouTube, there's lots of post-concussion exercise programs on YouTube. It's really about picking them specifically to your needs and your impairments and the things that are really bothering you. It's much more tailored to you than it is to the concussion itself.
Great, thank you. What has been the research results regarding exercise and cognitive improvement?
Okay, well, I probably should defer to Dr. Rutan because she's our cognitive expert. I'll just give a preliminary answer. I don't think the research really helps us yet as far as cognitive improvement. There's two problems that we've found in our research. One of them is that, you know, it's really hard to pick up on exactly the cognitive impairment people have after concussion, and then to look at whether it improved with exercise. So the first problem is we know that people with concussion complain of difficulty multitasking, attention and concentration, and things like that. So that's the things they complain of. But when we actually test them, we don't always get a quantifiable problem. So in people with multiple concussions, clearly that may be a benefit. But I don't think there's been a lot early on about the cognitive recovery. I don't know, Leslie, you probably are better in terms of longer term symptoms. I think that this is a question that might be more effective in a longer group, but I'll defer to Leslie.
No, it's a complicated question because there's so many different things that can affect cognition as well, especially after concussion, if people aren't sleeping well, or if they're on medication, or if they've got headache pain. So, you know, and exercise, you know, in terms of the, you know, the direct relationship, there's a lot of things going on there. So I think exercise may be helpful, but yeah, I don't think we have the exact answers yet. Nadine is asking, do factors like age affect the exercise plan?
Yeah, thanks for that question. So as most of you, as you may know, as we get older, our maximum heart rate and our maximum tolerance typically decreases. And that's related to age-related, usually declines in fitness that anybody on the street experiences, and age-related changes in your muscles, which I won't go into in great detail. However, the general rule of thumb when we're trying to estimate somebody's maximum heart rate is 220 minus your age. So as you get older, your maximum heart rate that's predicted for your age gets less. So if you're 50 years old, your maximum heart rate is predicted to be 170, whereas if you're 30 years old, your maximum heart rate is 190. So clearly, right from the start, because you're older, your prescription will change because your maximum heart rate expected is lower. And so we would definitely say that age has a factor in this, but it is calculated into our test because we look at where we expect you to get on the test based on your age. And we also look at how you're doing. So yes, definitely age comes into this, but it is related to known effects of aging on exercise tolerance.
Great, thank you. Kyle asks, is there any comment in the literature on any impact of a delay in implementing an exercise program after the injury? So for example, are there worse outcomes for people, or do people respond to the exercise therapy similarly, irrelevant of when it started? So basically, yeah, does it matter when you start doing your exercise?
Yeah. Okay. So thanks for that, Kyle. It's so yeah, so we do believe that exercise is helpful in as early as possible after the sort of 48 hours. And it does appear from the literature that delaying it will delay your recovery. So if you know, the earlier group seems to get better faster, as I showed you, than the later group. However, there's clearly, as you can see from the studies I reviewed, there were people who are more than 4 weeks following the injury and they started their exercise and they still seem to benefit. So it's still beneficial. It's just if you really want to take advantage of the window of recovery, it seems that the earlier the better. So as long as you wait for that 48-hour period or 24 to 48-hour period.
Great, thank you. Sheena asks, why do some patients have concussion-related headache for more than a year?
Okay, well, that's a great question. There's a variety of, we've been trying to understand this. There's a variety of different factors that perpetuate headache. And so we do know, it does appear that people who had pre-existing headaches, like migraine headaches, are more vulnerable to having prolonged headaches after a concussion. We also know that people can often get into a vicious cycle, like I explained, where they don't sleep well, they aren't able to do anything, and they get exacerbation of their headaches because with any activity, they really are intolerant and they get the headache. So this vicious cycle is very, very prevalent. And then there's many, many causes of headache, which each individual needs to be evaluated in their own. And we do have a nice thing on this in the concussion guidelines at the braininjuryguidelines.org/concussion. But I'll just make a comment that one of the problems we do see is that people get into what's called medication overuse headache, which is where they start taking headache pills and they then get into a cycle where they take a headache pill and then they get a rebound afterward. And if you take more than 7 doses of medication a week for your headaches, regardless of whether it's a migraine one like Maxalt, or it's Tylenol or Advil, or worse still, an opiate like Tylenol 3 or one of those ones, if you're taking more than 7 doses a week, you are very vulnerable to what's called rebound or medication-induced headache. So we just encourage people to be very aware at that time. If you've had one for more than a year, you really probably should be referred to a specialist in headaches to figure out, is this something that could be amenable to other treatments? Like we have Botox, we have preventive medications that we can give to people, tricyclic antidepressants, variety of different medications. And then we may just need to understand, is the neck triggering it? So is there something going on in the neck that may be prolonging it? So if you're suffering for more than a year, more than likely we need to make sure we're not missing anything else. And then if you're suffering with anything for a year, I would be remiss if I didn't comment on the mental health elements of that, which is if you're in pain and you can't do your normal life and you can't go to work, it would not be surprising that all the neurotransmitters in your brain that are important for how your mood is would start to decrease, and you would have lower serotonin levels, and your mood, then people who have low mood experience much more pain. And that's related to your limbic system, and the filters that are in your brain that relate to pain perception are upregulated so that you experience more pain. So you cannot separate the psyche from the soma, in that your mood is intimately linked with that vicious cycle. And so therefore, anybody who's had headaches for more than a year probably needs a comprehensive assessment of, what are the factors that are driving that headache. I hope that gives you kind of an overview of how we look at it.
That's great, thank you. John is asking how you alter the graded exercise program advancement if the patient isn't doing well or fails at a particular level.
Yeah, thanks for that question, John, because it is an important point to make. We will only progress people to the next level if they tolerated the level that we prescribed for that period of time. So if a doctor saw them this week, and they were prescribed a certain level and they failed at that, we would actually go backwards to the last successful level of exercise and to get them to stay there for longer. Like, so we're in week 4, they got through week 1 and 2 and 3 well, and then we went up to week 4 and they had a really bad week and there was no other reason for them having a really bad week. We would send them back to week 3 probably. We'd leave them there for a couple more weeks, and then we would go up to, you know, the sort of week 4 level and progress. So we definitely go back to the last successful level. We would not stop the exercise.
Great, thank you. Leslie's asking, as a concussed person of 2 years and age 66 living in Toronto, do I need a doctor's referral to access the Toronto Rehab Buffalo Concussion treadmill test?
So we're right now, our clinic is designed to study concussion right from the emergency rooms. And so we usually only follow people for a few months, but there are a variety of resources for people with long-term concussions. Certainly, my colleagues at the Canadian Concussion Center do see individuals. We also have the Toronto Acquired Brain Injury Network, takes referrals and refers them to specialists like physiatrists like me, who do take care of them. And that's another resource for you. I certainly think, as I said before to you, that, you know, if you don't have access to the test, you can certainly just evaluate, you know, by just doing a little bit of a standard exercise, getting a Fitbit, looking at your effort levels and doing a bit on your own, basically following that rule of know your limit and stay within it. I don't know if that helps, but I would certainly encourage you to think about that.
Great, thank you. We have a question. Can you suggest any study dedicated to post-concussion syndrome specific to MVA or motor vehicle accidents? As per my experience, it takes longer duration to see changes in MVA clients.
Yeah, so the literature definitely shows that being involved in litigation slows recovery. So that's the observation that's been made. It's not necessarily a cause and effect, but because it's an association we've observed. So, you know, I'm not sure that, you know, I'm qualified to give anybody advice about what they should do about their MVA related, you know, litigation if there was a motive, because, you know, they may have sustained injuries that require a certain degree of rehabilitation that they may or may not have got. However, I think if you're a clinician taking care of this group, you might want to educate them on the role that the MVA may be playing in prolonging the situation they're in. So to speak quite plainly, you know, if you've had an injury and you're not feeling well, one of the problems with our system is that you have to prove that you're unwell in order to get access to therapy and treatment and compensation. So you're constantly having to prove that you're unwell while you're trying to get better, which is a very hard conundrum, which most people have trouble navigating. So generally speaking, when you have an MVA person who's involved in a motor vehicle accident, it's really important that they see if they can settle the case, if there's a settlement possible, and really make sure that they can focus on their recovery. And then, of course, just think about making sure that you try and separate you from the litigation. So let your lawyer do the work and you just try and get better. So there's a number of things you can counsel people, but I don't think there's any research on this approach. The research just says that if you're involved in litigation, your recovery will be slower.
Thank you. Catherine's asking, she says, what can I do if I feel out of breath easily while exercising? So just even simply walking.
Okay, so this is a case where definitely you probably should see your family doctor and assess what is the reason for your shortness of breath. So lots of people have exercise-induced asthma, which is not related to a concussion. Other people may have other concomitant diseases. We don't know how old Catherine is, but you know, if you have any heart disease or other things that might be making you short of breath. So in general, if somebody feels out of breath, this might be the kind of person where you would want to go to your family doctor, be referred. They would do an examination and see, should I really send you to a respirologist to see if you've got exercise-induced asthma, where they would get you on a treadmill or an exercise bike, and they look at your breathing when you're exercising versus when you haven't, and they can see if your airways are constricting, or in the case of if there's a suspicion of a cardiac problem, they would send you to a cardiologist for a cardiac exercise where they monitor your heart and everything. So I think if you really are feeling out of breath and you've tried this, I do think that this is grounds for trying to get it looked into.
Great. We also have a question. Is this information generalizable to other types of brain injury? So outside of concussion, things like a hypoxic brain injury.
Oh. Okay, so the research, unfortunately, in hypoxic brain injury, so just for those people who are listening, may be curious what a hypoxic brain injury is. It's usually, it reflects somebody who became very sick in the ICU and they didn't have oxygen to their brain, or a person had a cardiac arrest. There may be people with more severe brain injuries, with more severe trauma than just a concussion. And I think the research is still much more developmental. I do believe that in the research that we do have, that it does appear that people who exercise have less mood symptoms, and they do seem to be reporting benefits from a perception of quality of life. However, there's not as many studies on people who had a cardiac arrest, because that group is a relatively smaller group. Thankfully, not many people have it. Unfortunately, we've seen a little bit of it with COVID because so many people are so sick. But we do see that exercise appears to benefit people who've had these other types of brain injuries for the very same reasons I told you. However, I don't think the research is robust or as systematic as we've done in concussion. So it's still under study.
Great, thank you. Jean has an interesting question. Does outdoor activity provide better results than indoor activity?
I don't think anybody's really looked at that. I think it's a personal preference. I mean, I personally am an outdoor person, and I like walking outside because I prefer to be in nature, and I get really bored running on running or whatever. But I don't think there's any research that's examined this, to be honest with you, in terms of concussion. I think in terms of exercise, there may be some research on that. But again, you can't always mimic exactly what you want to do on outdoors. So, indoors has some advantages in that you can get on a stationary bike and you can sit, you're not going to wobble. You're not afraid of running into another car. You're not afraid of your balance. If you're dizzy, you're fine. You can just get off. So there are some advantages of indoor, and likewise, there's some advantages of getting some nice, getting out in the outdoors and getting fresh air and getting sunlight and all those other things that are positive. So I think it really is an individual thing.
Absolutely, thank you. Stacy asks, can you explain POTS, please?
Sure. So POTS is postural orthostatic tachycardia syndrome. It has come into the media a lot lately because it is one of the autonomic symptoms that has been seen in people with post-COVID syndrome, or long COVID, or long haulers, as we sometimes call them. What it is as soon as any minimal exercise occurs, the person rapidly feels woozy because their blood pressure drops, and probably what's happening is the blood is pooling in their legs, so they don't get enough blood to their brain. The legs vasodilate, their heart rate suddenly skyrockets, so they feel like they've got palpitations of the heart. And it seems to be related to the regulation or the autonomic system in the brain. There is some people with concussion that do have some of these symptoms, but the most common, like recently, POTS is been more commonly seen amongst people who've been who've had COVID. And we think that it may be inflammation of nerves such as the vagus nerve, which travels down from your neck to your heart to regulate the heart rate. Really, we don't exactly understand it, but it is very much seen by some of the people who've had COVID. And occasionally we see this dysautonomia with people with brain injuries.
Great, thank you. Michelle asks, she says, I used to love walking and exercising and have had 25 concussions and shoulder surgery. I also have neuropathy in both legs from my hips to my knees. Is walking still safe, or chair exercises, she asks?
Yeah, that's a lot of issues that to make picking the right exercise challenging. I certainly feel like you may be better to consider cycling, like a stationary bike, and certainly chair exercises would be an option, because combining neuropathy, which affects the position sense in your legs, and the concussions and the balance, it may be just safer to do a chair program or a gentle program on a bike. So it just may be safer.
Great, thank you. I'm just conscious of the time. Maybe one more question. Mark was asking, did you say that there are treatment facilities for continuing symptoms?
So I was just saying that there are opportunities for people to get referred to concussion clinics, and the Toronto Brain Injury, Acquired Brain Injury Network does have, family doctors can make a referral into that, and then they will farm it out to the available clinics. And then my colleagues at the Toronto Western also see people with persisting symptoms. Unfortunately, I think it's pretty reality is there just aren't enough specialized programs to help everybody who has concussion symptoms. And so trying to navigate it is a bit of a challenge.
Yeah, absolutely. Okay, well, I think we're right at time. So thank you very much, Dr. Bayley, for an excellent presentation and answering all of those questions. And thank you for everyone that attended tonight. Just a reminder, we will be sending a very quick survey. So if you're able to just give us any feedback, we really appreciate hearing your thoughts, any suggestions for future talks. Just a reminder as well, in reviewing some of the surveys, just note that we don't actually know, they're anonymous. So we don't know who. There's been a couple of comments that I think people are expecting that we get back to them. So if there is a specific question you have, include some contact, because we don't actually have any personal information on you. We just get your responses to the surveys. So and we will be back in 2 weeks on October the 25th at 6. And we're going to have Dr. David Nicholas, who's going to be talking about neuroimaging in concussion. And Christian has just posted as well a link to the survey, as well as a link to all of the previous talks if you're interested in taking a look at any of those. So thanks very much and have a good night.